You're welcome. That is a great question. Oh, here he comes. Hey, Casey.
My what? Oh, you saw me?
I walked by and
I
I
saw
was
it.
like,
I'm grinding.
so chill right now.
Yeah, that's what.
Well, I'm-
We go. Neither did I.
No, I hope no one else likes it.
Oh,
Like,
really?
it's up to the 30. Oh, yeah. Okay.
May I computer person? Are you computer duty to start?
Oh, yeah, oh, yeah.
Alrighty.
It's so organized. We even plan to do something on the.
That's awesome. Oh, hang on just a sec. I'm gonna get the caption set up right for y'all.
As you said, yours might be a little.
Oh, wait.
Mine might be a little-
You all said you changed it, right? The link you gave me, that should still be right?
Just in the slides, it
Yes.
should be.
Yes, yep, that's it.
Yeah.
Yep.
Yeah, that's the on deck station.
Oh, and just for the folks on Zoom, if you go to Blackboard Group Project Materials, you can find their handout. So you can follow along. Alrighty, I'm gonna turn it on over here. All right. And thank you all for going first, by the way. Of course.
Okay, so our topic is on epilepsy. So I wanted to do a little brief introduction before we got into everything. about what epilepsy is. So it's a disorder in which nerve cell activity in the brain is disturbed, causing seizures. And it is one of the most common disorders of the nervous system and affects people of all ages, race, and ethnic background. And according to the CDC, almost 3 million Americans live with epilepsy, and nearly 200,000 people in the US develop this condition annually. So some symptoms for epilepsy. Before an epileptic episode, an individual may feel a euphoric aura, which is the feeling of feeling detached from reality, very strong emotions, tingling sensation, or dizziness. They may also experience temporary confusion. Postictal agitation and paranoia commonly occur in the immediate postictal state, and this typically begins 1 to 3 days after a seizure. An individual may also experience episodes of staring blankly, and during an episode, an individual may experience jerking movements or twitching of the arms and legs. Individuals may also experience loss of consciousness or awareness. And someone with epilepsy also experiences psychological symptoms. This includes fear, anxiety, and depression. Mood symptoms are very common with patients with epilepsy. These symptoms have a significant impact on a person's quality of life. People with epilepsy have a higher risk of suicidality than the general population. They may also experience episodic cognitive dysfunction caused by unrecognized seizures. And people with epilepsy may also experience sleep disturbances, and that may cause daytime drowsiness, problems concentrating, and increased seizures. And they may also experience disturbances in their memory. And some signs someone has epilepsy are abnormal neural activity on EEG. And epilepsy features abnormal electrical activity in the brain. There are several varieties of seizures someone with epilepsy may have that will cause abnormal discharges of neurons. And this occurs from scarring from an injury, infection, tumor, or it could be genetic. Some unprovoked seizures, two unprovoked seizures, at least 24 hours apart, is a sign someone may have epilepsy, and that is used to diagnose. And then Casey will explain the picture.
Okay. So yeah, here, EEG, the electroencephalogram, you can see kind of the differences between a patient who has epilepsy versus normal or seizure-free, where there's this hyperactivity in the brain waves, which is pretty characteristic of the overall brain activity, which I'll go over more. So like for the related brain dysfunction, like most disorders, it's a very complex, there's very complex causal origins of what causes epilepsy, and there's a range of neural symptoms and other things that might cause neural disturbances. So the structures differ from full lobes to structures to more like localized specific places. So the lobes involved are temporal lobe, frontal lobe, and like the olfactory cortex. And then more specific structures are the thalamus, amygdala, cerebellum, and then even more localized are specific dendrite synapses and receptors. So when you disrupt the mechanisms that inhibit firing or promote the mechanisms that facilitate excitation, seizures can occur. And when you disrupt mechanisms that bring neurons close to firing or enhance inhibition, you can prevent seizures. So basically what that means is excitability increases seizures, while overall inhibition decreases seizures. So this shows that the neural activity is just hyperfiring and erratic communication between neurons. So on the figure to the right, it shows how different regions of the brain actually produce seizures that differ in symptoms. So depending on where the localized origin of the seizure occurs, the manifesting symptoms may change. So the factors that alter this excitability and inhibition balance can be genetic or acquired. And the genetic cause can differ many levels of brain communication, all the way from the circuit level to receptor level and even ion channels. So also brain injuries or cerebral insults can alter circuit function. So some more brain dysfunction. This shows how there's also a genetic component to epilepsy and how it can be monogenic or polygenic, but like most complex brain disorders, it's really a combination of mutations that are working together towards producing the overall state of excitability, where one gene itself isn't necessarily responsible for causing epilepsies. So our second point, studies have shown that these genetic basis, multiple genes contribute to this altered cellular excitability, which underlines the epilepsy neurocauses. Also, another related cause could be blood-brain barrier dysfunction, where the blood-brain barrier is basically the region of the brain that separates ions and molecules and unwanted substances from the blood of the body into the blood of the brain, and how dysfunction in the blood-brain barrier can actually contribute to this excitability and can be involved in seizure generation. And then also other causes are like traumatic brain injury and other brain injuries or cerebral insults. And these actually account for 10 to 20% of symptomatic epilepsy, and 5% of all epilepsy is caused by this post-traumatic cause. So our figure on the right kind of breaks down this neural communication, how if you think about it as neurons connected are like streets and traffic lights, and how these neural streets connect the different areas of your brain, and how dysfunction on the local area of connected neurons, when they fire uncontrollably, produces a focal seizure, and how that can spread throughout the brain if you think how interconnected they are. And then lastly, to summarize brain dysfunction, they can be brain injuries such as strokes, tumors, and traumatic brain injury can generate epilepsy by altering brain circuits and how the brain connects. And also brain dysfunction can be caused by more genetic factors, and this overall state of increased excitability and sporadic neural firing, as well as dysfunction with other central nervous system aiding structures. They can all lead to brain dysfunction for epilepsy.
So moving on to assessment.
The purpose of a neuropsychological assessment in epilepsy is to specifically identify the patient's strengths and weaknesses. And this can help a patient receive aid in different ways, depending on their age and context of their daily lives. For example, academic accommodations or guide vocational planning. Moreover, information can also be helpful in making differential diagnoses. For example, if a geriatric patient has both Alzheimer's and seizures, it can help differentiate if it's because of the Alzheimer's or if it's because of the seizures. And it's also helpful in monitoring effects of non-surgical treatments like physical therapy or medications. So this is a little video I have of a woman who is a neuropsychologist that helps with children dealing with epilepsy. Do I need to do something for the volume?
Thank you. That's why I sit right over here when y'all present, so I could be tech support. Yeah, it's just coming through the wrong speakers. This happened in my other room today too. Wait, that's there we go.
Hi, I'm Shauna. I'm one of the neuropsychologists attached to the epilepsy surgery team here at Birmingham Children's Hospital. I'm going to talk you through what to expect when you come to the hospital for your neuropsychology assessment. I'll bring you into my office and we'll sit down and talk through some of the tests that we're going to do. These will be pencil and paper type tests, looking at things to do with memory, looking at how you solve problems, how you do things at speed, and how well you can think through problems generally. Have you seen these blocks before? Yes. One of the tests that we might ask you to do would be to copy pictures using three-dimensional blocks. This is looking at how well you can process visual information. Another test that we use is a memory test. Children with epilepsy quite often have memory problems, and so we'll be reading out numbers to you and asking you to repeat those back to us. 9, 4.
9, 4. I don't know what to expect today. The assessment that I'd done was pretty much like schoolwork. It was quite relaxing, so I didn't have to worry about much.
So hopefully you'll enjoy coming along to do these tests. They'll be fun. We'll have frequent breaks because it will last a number of hours. Once we finish the tests, I will go away and score the results up and prepare a report which will be made available to your mum and dad. The report also goes to the other professionals, the other doctors and nurses who are working in the team, so that together we can make a decision about whether or not epilepsy surgery is the right option for you.
I hope it'll give me a much clearer view on what will happen on the next visit to hospital. Hopefully my doctors will point me in the right direction and I'd have a much better view on maybe the future if I have to go under surgery.
So that gives you a good idea of what to expect. And it's a little different for an adult test, but next slide. So initially, they're all neuropsychological assessments. There's a clinical interview, a neuropsychological test battery, and then it leads to interpreting and reporting test results. So beginning with the clinical interview, it wasn't very touched upon in the video, but this is where the clinician makes relevant hypotheses that will guide the choice of assessment procedures. So kind of just as a basis of like them understanding the patient and like how they will assess them. So they'll obtain a description of the symptoms and important historical elements while observing the patient's behavior in an open-ended condition. For example, they can ask specific questions regarding the characteristics of their seizures and how that affects the patient's cognitive and behavioral functioning and how the patient feels about that. And it also can be useful to help provide information to the patients and allows them to be able to ask questions regarding the nature and the purpose of the assessment that's going to be coming. And they tend to focus directly on the effect of their daily life and the seizure history in specific. So moving on in application to the case study, we assigned a case study for a very extreme case of seizures and epilepsy. So in specific, it was about a 28-year-old male who had shakes when he was 12 months old that required shots. This also had frequent spells during his childhood that responded to steroids and eventually ceased. He had normal development after the spells, but had noticeable loss of cognitive function, which delayed his development. And he had developing episodes where he would become rigid and would abruptly fall to the ground and often resulted in injury. And he had prominent grand mal seizures, daily episodes of staring, seizures, and pseudo seizures, which were reported based on bizarre behaviors and jerking that would occur despite being fully conscious. So upon like a clinical neuropsychological assessment, it'd be helpful to like look at these symptoms and assess them and figure out what's really going on with him and just checking on his behavior and his cognitive ability and how he has strengths and weaknesses in different areas to really assess the full thing that's going on in his brain. So looking at a neuropsychological test battery, there isn't really a universally adapted approach to conducting a neuropsychological assessment in epilepsy patients. They usually use like a hybrid where they like take tests from other things and just have a core set of tests and just add and subtract other ones as they go. So the key things they focus on in epileptic neuropsychological tests is intellectual functioning, which can be assessed in the WAIS, and which is an intelligence test. And also with the WAIS, they will look at the digit span as a subtest, focus on attention and processing speed. And for executive functions, they will often use the WCST, which is the Wisconsin Guard Sorting Test. And they can also use tests like cerebral fluency to look more at executive functioning. For motor and sensory function, they usually use the Eidenberg handedness inventory, which is really useful for figuring out if there's unusual combinations they have. Like, for example, if someone is left-handed and they start using their right-handed more or something like that, you can kind of see how they have like a physical thing going on there too. And also they can accept language through tests like the PCI, which is the Verbal Comprehension Index, the Wide Range Achievement Test, and also the Wechsler Individual Achievement Test. And also you can test visual, perceptual, and spatial skills. And you can use the judgment of line orientation and the facial recognition test for that. And moreover, something they really like to focus on is learning and memory, as addressed in the video, and how Brecken said most patients have concerns about their memory functions. Actually, 70% reported having subjective concerns about their memory functions at any given time. So they kind of focus on rote learning and story recall and figure recall for that to assess how well their memory is working. And also performance validity testing is useful in neuropsychological tests to just figure out if the tests are accurate and valid. And another thing Brecken kind of touched upon is mood and personality is a big thing they also like to test on in epilepsy, because unfortunately, epileptic patients have increased rates of psychiatric disturbance, meaning like depression and anxiety, and also different kind of personality things. So they like to use the Minnesota Multiphasic Personality Inventory, the MMPI, and the Personality Assessment Inventory, the PAI, which is helpful. So once they're done using all the tests, they often score the test using their descriptive scorings, which are different for each test, and they interpret them, and then they communicate the results to the patients, referral source, and other healthcare professionals.
So I had treatment, and Caitlin was talking about how like they have lots of memory issues, and that's a concern for them. So I don't have a slide for this, but one of my teammates has epilepsy, and he like explained to us how it affects his memories, and how so many things that he has to do on his daily life are things to help correct or aid him in his memory problems. So he has a daily schedule that's written out that he carries to everything, so he can make sure he can get there on time. It took him a while to like learn our names, just because putting the names to faces takes him a little bit longer. So like he asks us to be patient with him. So like things of like, if you have someone in your life that you know has epilepsy, there are many things that you can do to help them, like just being patient with them, or like giving them constant reminders about things, like, but like be nice about it, you know? So that was interesting. She said that, and then it's like, I have this teammate that I swim with every day who deals with these sorts of things. So the different types of like treatment, they usually start with medications. So they'll have drugs for epilepsy that are used to help assuage the somatic symptoms, because there aren't medications that will reverse or prevent the epilepsy. And they're called anti-seizure drugs or anti-epileptic drugs. There are over 20 different like medicines, like they have so many different ones that they can put you through trials for or testings for. And they'll aim to either increase the effects of GABA, which is an inhibitory neurotransmitter in the brain, or they would aim to reduce the use of glutamate in your brain, which is an excitatory transmitter, like Casey was talking about. So there are lots of possible side effects that come with any medications. So the epileptic medications are not an exception to this. So some of the side effects that are early onset could be things like dizziness or drowsiness or gastrointestinal issues. But then there are also like late onset side effects if you're taking the medications for a very long time. These could be things like depression or behavioral issues or psychotic episodes like Caitlin was talking about. But the late onset side effects are pretty rare. Like you don't usually have to deal with these sorts of things, but they are a possibility to keep in mind. So I have these charts that they list all of the different medications up on the top, and then the red is the high risk, the yellow is the medium risk, and the green are the low risk for the different symptoms. So you can like kind of see the different things, like some of them might aggravate your seizures or cause those gastrointestinal problems, like I was saying, or hypersensitivity or rashes, which are skin conditions. But you can see those are pretty medium risk. Then we have the late onset adverse side effects, and you see that there are a lot of different possibilities here, like the depression or the psychotic episodes. There are things that could do with your livers, or this just comes from taking the different medications. It can cause weight gain or weight loss. So these are always things to keep in mind, and remember, you can always try lots of different medicines that your doctor will like talk with you through, and you can try them for different amounts of time. So if there are side effects that you really can't live with, there are always tons of other options that you can try through. But there are alternative treatment plans. There you have like 3 things that they will usually go through. So if you have drug-resistant epilepsy, it's usually characterized by 2 failed medication treatment plans, but also they usually take a really long time of like you living with epilepsy and trying the medications before they go to like a different step or claim you drug resistant. So like the next step would be considerations for surgery. So about 15% of people with epilepsy are drug resistant and would have this consideration for the surgeries. The surgeries would, their goal is to disconnect or destroy the epileptic tissues. So they would do lots of work targeting where in your brain exactly your seizures are coming from, and then they would carefully try to remove them or disconnect them. And like I said, since it takes them a while to get to this point, this is like a last resort. So it usually takes around 20 years after the onset of your epilepsy before they take you for surgeries. Another alternative treatment plan, they've been researching and experimenting with the use of medical cannabis. So this is a hot topic in the world today of whether this should or shouldn't be used for medication. So they've had a few experiments with the cannabis and has been successful. It works better than their placebo control groups, but it is still not approved in most places. So this might be something to look out for in the future of whether it will be a great medical care or if it was just a thing that we could have tried. And then a last kind of alternative treatment would be the vagus or trigeminal nerve stimulation or deep brain stimulation. I know we talked about this in like really drug resistant like depressions and other things. So like this is something else that they try as like a last resort for their epilepsy. And it has helped more than half of the people that have the drug resistant epilepsy, but it's still very uncommon to get to this point. And then we have Sarah with our quality of life.
All right. So for quality of life, it's important to note that specific to epilepsy, there's no, one universal quality of life measurement. So these are a list of some of the commonly used methods to assess quality of life in patients with epilepsy. So some of the main ones I found were performance, subjective evaluation, and socio-demographic data. And this one mainly measures the epilepsy severity, the health-related quality of life, limitations in daily living, and psychosocial concerns. And this one is also self-administered or conducted in a face-to-face interview. And then there's also quality of life in epilepsy. So this one, very specific to epilepsy. So again, it's going to measure health-related quality of life, emotional well-being, energy and fatigue. If you have anxiety over your seizures and anticipating your seizures, also takes into account medication effects, health status, as well as cognitive and social function. And then some of the less commonly used ones include the well-being scale, quality of life assessment schedule, epilepsy surgery inventory. And then the article that I got all of this from was talking about the neuro quality of life short forms. And these include some different measurements that aren't usually seen on the epilepsy quality of life tests that include sleep disturbances, depression, behavioral and emotional discontrol, and positive effect or well-being. So I have like 2 videos to give kind of a personal insight from someone with epilepsy.
How it changed my life. And when I mean it, I mean epilepsy. Quick disclaimer, my hair looks a mess, but on a serious note, everything said in this video is my opinion, my experiences. I remember I had my first seizure when I was about 7, and I remember that day like it was yesterday. After that, I remember going to the hospital and just waking up, obviously with oxygen mask on my face, and just shocked, thinking what just happened. And yeah, it was a weird feeling, a really weird feeling. But because at the time I was really young, like I didn't really think much of it, and it took a while. It took quite a few weeks of going back and forth, and eventually got referred to a specialist, and that's when I found out that I had epilepsy. The only thing I was thinking, and that was really scaring me, was the fact that I was thinking those symptoms that I had 15 minutes prior to having the actual seizure, I just didn't want to experience again, like the shortness of breath and seeing stars, feeling like you're gonna fall over, like, and they all intensify as you get closer to the seizure. And I was just thinking, I don't want to experience that again, let alone experiencing the seizure, having the seizure and waking up and feeling weak, like you haven't slept for days, and just feeling like you've been beaten up and feeling really sore. I just didn't want to experience that all again. I remember asking the specialist, is there anything you can do to guarantee that I won't experience that again, at least? Like, please, is there anything you can do? And obviously they couldn't, and that was what really just that was the tough part, man. That was the real tough part about being diagnosed with epilepsy, knowing that I'm gonna have to go through all of that again, all like frequently. It's just, and I've never experienced anything like it. And it's like, even now to this day, just before I have a seizure, the symptoms I have, it always feels like that's gonna be my last breath, like I'm gonna pass away. Like it's just that traumatic, like, and you never get used to it. That's the scary thing, you never get used to it. Like, till this day, it's the scariest thing I've ever witnessed. And I usually get like really emotional during that period, just before I have a seizure. Slighting things up a little bit, prior to my diagnosis, I knew nothing about epilepsy. Like these lot here, they're probably thinking, what am I doing? But yeah, I knew nothing. Anyways, one sec. Like I was saying, I didn't really know much about epilepsy prior to my diagnosis. And yeah, I didn't realise how bad epilepsy affects you in terms of, I feel like my anxiety. Just to add on to that, I think the worst one for me is anxiety and panic attacks. Boy, man, it's really hard to remain calm when this happens, because at the time I'm thinking, is it really gonna happen? Am I gonna have a seizure, or is my body just, or my mind just playing tricks on me? And yeah, like, I hate that, man. And that's the toughest part, like when you get anxiety, because some of the things I'm feeling is very similar to how I feel before I have a seizure. So yeah, confidence is really affected as well, which is probably a bit odd considering what I'm doing and being behind camera and whatnot. But yeah, sometimes you don't feel like going outside, and confidence is really affected. Yeah, man, there's a lot of things that people don't realize that happens when you have epilepsy, if that makes sense. Because I got diagnosed when I was very young at the time, I don't really remember there being that much information out there. All I remember is a specialist saying that you're gonna have to start taking this medication. Which brings me on to my next point. Your interactions with people really do change. So anyways, here's a few examples. First, you have the know-it-all. So how's the weekend been anyway? To be honest with you, hasn't been that great. I had a seizure, I've been in hospital. No way, you serious? Yeah, do you know what? I've been doing a bit of research, and I've got to say, you've been eating, your diet hasn't really been on point. You've been eating a lot of eggs of lately and stuff like that. You really need to change up your diet. That might do the job, you know? Really? Get your diet intact. It's all about the diet. Also, stay away from video games, stuff like that, TVs, all of it. It's all bad for your head. Just go for walks, rest. Then you have the rude person. You got to sort it out.
Okay, so that kind of gives you like a general idea of living with epilepsy. And then I had another video.
How it changed my life.
Let's see, how do I go? There we go. Okay, this one's a little bit shorter. And this one kind of touches more outside of the patient, how it can also you know, have an impact on your family.
I'm Claire. I play piano. I am a freshman in high school, and I used to have over 200 seizures a week. When I have a seizure, I rock back and forth. I'll pound with my hands. I breathe very heavily. Embarrassment was a big fear of mine. I feel like people are gonna judge me. It gets hard.
So every part of our life became, if she would have a seizure, what do we need to do? How do we prepare for that? I started thinking of this as our new normal, because first line of defense is medications, and they weren't working.
70% of patients with epilepsy will respond to medications, but there's a 30% that is not responsive to medications, and those are the population that we want to at least consider for epilepsy surgery.
When we found out that she was a candidate for surgery, we were definitely happy for her that this might be our key to being seizure-free someday. But again, it's also brain surgery.
I wanted to do the surgery because I knew the medication wasn't fully gonna control it.
This is what she wanted, and we had to listen to what she wanted. But we had complete trust in the doctors at Vanderbilt. We knew we had to do this for Claire.
So the ROSA robot allows us to very precisely insert electrodes or laser fibers to targets inside the head. Once we did that, it clearly showed us this area in her brain where the seizures were coming from. And it allowed us to then plan a surgery to remove that area to treat her seizures.
My removal surgery did work. I have been seizure-free since August 26, 2019. I feel like I have had this weight lifted off of my shoulders.
It has been a journey, and the care at Vanderbilt is top-notch. I truly believe we would not be here today without Vanderbilt.
Okay, so a little bit of a promotional moment there, but yeah, it kind of gives you another idea of how people with epilepsy are affected in their day-to-day life. So some of the other, just kind of to summarize the videos that we saw, you can see how people with epilepsy often deal with a lot of embarrassment, physical exhaustion, sometimes difficulty with relationships, just because of, social exclusion. If others, there's still a stigma around epilepsy, and people, may be judgmental towards people with epilepsy. And there's also, of course, there are laws in place to prevent this, but of course it still happens. There can be denial of employment as well, even if a person with epilepsy, their seizures would not affect, their place of work. So some other studies also went into predictors of quality of life. And these included age at onset, number of medications, and it also went into parental depression, I guess just kind of relating to the family structure and the support system, and how that can, influence your quality of life as well. And then some other predictors included intentional problems, intelligence, family structure, and parental anxiety. And then an increase in seizure frequency, severity, level of depression and anxiety. And if you had a previous condition, were strongly associated with a lower health-related quality of life. So those are all things that can go impact your quality of life. And also, I feel like one group that we forget about sometimes, older adults and the elderly. They can also be affected a lot by epilepsy if they have, mobility issues, reduces due to physical changes. And also if you happen to be a person with epilepsy who can't drive a vehicle, and that can definitely impact those older individuals. But yeah. And then another study, this was on quality of life using schedule for evaluation of individualized quality of life direct weighting. This is kind of on a more positive notes that related to a good and better quality of life standard. For patients, those who had good awareness, knowledge, and attitude towards their condition, they were able to, reach more self-efficacy and have a higher quality of life. And it also definitely helped when they had family support as well. And then for family members of those patients with epilepsy. They also had higher quality of life scores when the patient had a high knowledge about their medication, along with them having a higher activity level. And there was also some correlation with family members who are retired having a higher quality of life, rather and those who had relationships outside of the one with the patient as having a higher quality of life. So these are all factors that, you know, can affect quality of life, and really just having a great support system and knowledge about your condition can help you have a better quality of life. All right. And then these are all of our references. Okay.
Thank you. Well, you were like spot on. 35 minutes, there you go. I wasn't even watching. I was like, hey, you go. All righty. Any questions for the group? Cool. Well, again, thank you all for being willing to go first. Very educational. Just a reminder for everybody that there will be multiple choice questions on the take-home final about each presentation. So your handouts will be helpful for that. And then their PowerPoint is posted with Google Slides, and their article is also posted under group materials. So you will have access to all of that. So we do have a presentation Monday, so please do try to be here. Thank you to the 2 people who were presenting today who came. We appreciate the support. And then, yeah, no class next Wednesday because it's the day before Thanksgiving. I am out of town at a conference. I'm basically gonna like get stuff ready and then head out, fly out tomorrow morning. So I will not necessarily be checking my email, but I'll try to catch up on it on Monday and Tuesday. So, everybody have a great weekend.
Professor?
Yeah.
Oh, sorry. I just wanted to ask when our group was presenting.
You find that out when you meet with me, and y'all haven't met with me yet. So
Oh, okay. I just scheduled it for Tuesday, so.
Okay, perfect. So yep, we will do it then.
All right. Thank you. Sorry.
No problem. Bye.